Hi everyone. Today, I will be presenting our research, a multicenter retrospective study investigating the effectiveness of corticosteroids in different clinical phenotypes of community-acquired pneumonia, or CAP. Let's begin with the study design, as shown on this flowchart. This was a large, retrospective analysis conducted across 4 clinical centers in China, ultimately including a total of 4,257 hospitalized adult patients with CAP. The patient data came from 4 distinct cohorts: the Xinhua Respiratory Cohort, the Xinhua Emergency Cohort, the Second Hospital of Jilin University Cohort, and the Huainan First People Hospital Cohort. This multi-center approach helps ensure the diversity and generalizability of our findings. The primary goal was to use this data to identify distinct clinical phenotypes of CAP patients and then evaluate the impact of intravenous corticosteroid therapy on their outcomes, using advanced statistical methods to ensure robustness. Moving to the core results. Through unsupervised clustering analysis of demographic and laboratory data, we successfully identified 3 distinct clinical phenotypes among CAP patients. Let me briefly characterize them. Phenotype A patients were generally younger and had fewer organ dysfunctions. Phenotype B was an intermediate group. Critically, Phenotype C was the most severe. These patients presented with significantly elevated inflammatory markers and evidence of multi-organ dysfunction. Consequently, they had the highest rates of ICU admission, the longest hospital stays, and the highest mortality. The key question was, do corticosteroids help? Our analysis revealed that the answer is not the same for everyone. It depends heavily on the phenotype. When we applied advanced statistical models, including a marginal structural model to control for time-dependent biases, we found that intravenous corticosteroid therapy was associated with significantly improved outcomes, but specifically and most strongly in the high-risk Phenotype C group. Furthermore, we identified an optimal treatment regimen for these severe patients: a dose of 80 mg per day of methylprednisolone equivalent, administered for no more than 5 days. So, let's crystallize these results into the key takeaways from our study. First, we demonstrated that CAP is not a single disease but can be stratified into at least 3 clinical phenotypes with vastly different outcomes. Identifying the severe Phenotype C early is crucial. Second, the debate on corticosteroids in CAP needs refinement. We showed that their benefit is phenotype-specific. They are not for everyone, but they are highly beneficial for the right patient, the Phenotype C patient. Third, we defined a precision treatment strategy for these severe cases: an optimal dose of 80 mg per day of methylprednisolone. And fourth, we found that the duration of treatment is critical. It should be limited to 5 days or less to maximize benefit. In short, a one-size-fits-all approach does not work for CAP management. In conclusion, our study makes key contributions to the management of community-acquired pneumonia. This multicenter retrospective study analyzed 4,257 CAP patients and identified 3 clinical phenotypes: A, B, C. Phenotype C was the most severe, with higher mortality and organ dysfunction. Using advanced statistical models, logistic regression, Cox model, MSM, the study found that intravenous corticosteroid therapy, particularly 80 mg per day methylprednisolone for less than or equal to 5 days, significantly reduced mortality in Phenotype C patients. These findings support phenotype-guided corticosteroid therapy to optimize CAP treatment. Thank you for your attention.